Welcome back to another video of A&P Madness with Dr. H. This will be the last of the acid-base balance videos, and in today's video we're going to be looking at some acid-base disorders, and we're going to try to solve these acid-base problems, trying to diagnose what is wrong with that patient. Okay, before we can go and do these steps to solve acid-base problems, we need to be able to understand one last bit of detail that was not discussed in any of my previous videos, and that is the primary causes of acid-base diseases, okay? The primary causes. Now, I have over here, if it's CO2 related, we call this a respiratory problem. If it's not CO2 related, we call it a metabolic problem. It's a pretty easy way to differentiate acid-base disorders because they're either going to be CO2 related, the number one source of acid in the human body, or they're not going to be CO2 related. If it's CO2 related, we call it respiratory. So what if it's acidosis? Then we call it respiratory acidosis. Nice. What do we know about respiratory acidosis? It's a CO2-related disorder that's causing acidosis. So, what do you already know? There's too much CO2. Just by thinking through a couple of little problems, we know that in respiratory acidosis, we have an increase in CO2. Piece of cake, right? What is going to cause something like an increase in CO2? Any disorder that causes hypoventilation will do the trick. Any disorder that causes a decrease in breathing will do the job. How cool is that? Lots of things can do this, from COPD, asthma, chronic pneumonia. But there are other things as well that can cause hypoventilation. Let's write some of these in, by the way. Let's go ahead and write some of these in. We have, I just don't have a ton of room, so I'm going to try to put this in small. But if we have something like COPD, if we have asthma, if we have chronic pneumonia, chronic pulmonary edema, anything along those lines would do this as well. I could write chronic because if it's acute, it's actually going to cause alkalosis due to compensatory mechanism. So let's go ahead and write chronic so you guys keep that in mind. Chronic pneumonia. Those are going to do it. Now, there are other causes, though, other than an actual disease of the lungs. What if we have a CNS depressor? What if we have opioids or alcohol? So anytime that we have a patient that has taken a drug where we have a CNS depressor, that's going to start to cause hypoventilation in those patients, and that's going to result in respiratory acidosis. Awesome. Let's do another one. All right. Let's say, what if it's not acidosis? What if we're dealing with alkalosis? Okay, well, if it's a CO2-related disorder, then it's respiratory alkalosis. Okay, I'm going to go ahead and go over this way. And if we have respiratory alkalosis, then we know it's a CO2-related disorder. That is CO2. There's a decrease in this patient's CO2. 1 second, my kid's asking me a question. Good old 3.5-year-old. Oh, that one's really cool. Oh, no. Not yet. Maybe later, okay? I love you tons, kiddo. All right. Sorry about that. I don't edit that sort of stuff out because life happens when we're stuck here at home doing these videos, and life is kids, and they're amazing. Okay. So if we have a decrease in CO2 levels, that's going to cause alkalosis. Why? Because CO2 is the number one source of acid. We got ourselves that carbonic acid, right? So now we have too little carbon dioxide, therefore alkalosis, not enough acid. So anything that would cause this, okay, well, let's think about what would cause this. Well, there's really only one thing that would cause this when it comes down to it. then that's hyperventilation. Any disease or any scenario that causes hyperventilation will result in respiratory alkalosis. So let's look back at, say, acute asthma, right? When you start having that asthma attack, it causes hyperventilation. Or if you have pneumonia initially, that's going to trigger receptors in your lung trying to fix the problem, and it's going to cause hyperventilation. So that's why acute pneumonia or something along those lines will cause hyperventilation. So let's go ahead and write in something like acute pneumonia, or even acute pulmonary edema would do this. What else would cause hyperventilation? What if there was a decrease in the amount of oxygen in the area? Okay, what if we had hypoxia? That's going to cause hyperventilation because of compensation. What other things can cause this? Oddly enough, things like pregnancy. Right? Pregnancy causes an increase in progesterone, and progesterone goes to the respiratory centers and increases the activity of the respiratory centers. Other things, well, unfortunately, many people have had panic attacks. So any sort of anxiety disorder will end up causing an increase in hyperventilation, right? We have an increase in the ventilation rate. There are other things as well, hypothyroidism, sepsis, these sorts of things can end up resulting, depending on whether it's acute or chronic, either in alkalosis or acidosis. Depends on whether it's causing hypoventilation or hyperventilation. Pretty simple idea. It's all CO2 related disorders. Now, on the opposite end of the spectrum, what we have is, if it's not CO2 related, we're dealing with metabolic. So let's throw in some metabolic acidosis. Now we have a lot more things that can really cause this. But ultimately, when we're dealing with not CO2, what we're really asking ourselves is what's happening to hydrogens? Okay, because there are other sources of acids, right? Lactic acids, amino acids, fatty acids, ketonic acids. If we end up with any sort of increase in the hydrogen concentration, wherever that's coming from, those excess acids cause acidosis. Or we don't even have to have an increase in the number of acids. We can simply have a decrease in the number of bases. Right? Whatever those bases are, the primary base, of course, is bicarb. So anything that causes a patient to lose bicarbs is going to cause this as well. So let's look at something that would be a cause, right? If we lost bases, how can we lose bases? Ooh, something like severe diarrhea. This is the number one case that I use in my classes to describe these loss of bases, because as you have diarrhea, as that fecal content and the fecal volume goes up, well, that's because the large intestines isn't doing a good job at absorbing water. But why isn't it absorbing water? Because it's not absorbing salts like sodium, potassium, chloride, and it's not reabsorbing bicarbs that have been secreted into that system. So something like severe diarrhea, we start losing the bases in the system. Those bases aren't in the blood anymore to bind up hydrogens. Okay. Other things that will end up resulting in acidosis, alcohol intake, because of the effect of alcohol on bases and the increase in the number of acids in the blood. Not only that, but alcohol, remember we said it can cause hypoventilation, which can cause a mixture of metabolic acidosis and respiratory acidosis. It's kind of bizarre that way. Other sorts of things. Ooh, diabetes. Okay, especially diabetes mellitus. This is going to end up causing ketoacidosis. Ketoacidosis is pretty severe, and it's going to cause that increase in ketonic acids and also concomitant like amino acids and lactic acids and fatty acids and all that other stuff. So diabetes is definitely a severe source of hydrogen intake. Exercise. I mean, this list goes on and on. That's not how you spell exercise. Renal failure. There's all sorts of things that can cause this. Renal disease, adrenal insufficiency. The list is very, very long in terms of the things that can cause metabolic acidosis. All right, last but not least, we also have metabolic alkalosis. You guys can probably have a pretty good understanding of what we're going to say, right? If it's not CO2 related, then it's either hydrogen or a base related. Alkalosis means we have too many bases. So if we have an increase in the concentration of bases, or we have a decrease in the concentration of hydrogens, either one of those is going to do this job. A great example is if we lose hydrogens. What's a source of hydrogens in the human body? One good source is hydrochloric acid being produced in the stomach. So if we start to vomit excessively, then we start losing hydrogens. Yeah, they were in our stomach, but they should have been recycled and brought back into our bloodstream. So they are no longer available to help be acidic in our bloodstream. Other things, ingesting alkaline substances, please don't do that. But I mean, even low levels of Tums could end up causing the acids to be bound up. But yeah, ingestion of alkaline substances is not something you should really do. Diuretics, this is a great one. Diuretics can actually end up causing excessive loss of potassium, and the second we start losing potassium, the body is going to try to reabsorb more potassium. You might recall these are the type A intercalated cells that are going to be doing this. And type A intercalated cells, as we lose potassium and we reabsorb that potassium through the type A intercalated cells, that's compensation for the potassium. At that same time, we're going to be, unfortunately, secreting a lot of hydrogen. So as we lose potassium, we try to retain potassium, but then we lose hydrogen, which makes things more alkaline, right? So there's quite a bit that can end up causing metabolic alkalosis. Whew, how the heck do we therefore say, we got a patient that comes through the door, all we have is their blood. How are we going to determine what disorder they have? I hope you guys can start to see that the list is huge and it can be very overwhelming very fast. But it's really not that bad to get started. There is a very nice set of steps that you can walk through in order to determine what's wrong with that patient. Okay? The first step you can do is blood work. So you're going to do blood work. There's all sorts of blood work that you're going to order from the labs. But let's just go ahead and write in, we're going to get some blood drawn and we're going to send it to the labs. Now, for my students, you don't need to know this for exams. Other students might want to know that you're going to get, chemistry panel, you're going to get lactate, you're going to get the VGB and the ABG. So those sorts of things you're going to be after. But when you look at that blood work, the next thing that you're going to be getting with that blood work, you're going to be getting in their blood panel, you're going to get their blood pH. It's part of the workup. So after we get that blood work done, we will know what that patient's blood pH is. So let's look at it. What do we know about pH? There's a normal pH level of 7.35 to 7.45. And if it is less than 7.35, what do you know that patient has? Acidosis. And if it's greater than 7.45, what do you know that patient has? Alkalosis. You don't care whether it's respiratory or metabolic at this point. You only care whether or not that patient has acidosis. And that's something nobody ever can take away from you. If the patient's pH is less than 7.35, don't worry about any other variable yet. If it's less than 7.35, you just straight up say this patient has acidosis. There shouldn't be a doubt in your mind. If it's greater than 7.45, this patient has alkalosis. There shouldn't be a doubt in your mind. The next thing you guys are going to do is you're going to determine the primary problem, right? And that's what we have here. The step 3 is it respiratory based or is it metabolic based? And you're going to be doing this by measuring bicarbs and also as you drew their blood, you will be getting a partial pressure of the amount of carbon dioxide. So you're going to be looking at their bicarb levels and the partial pressure of CO2. What do we know? If it's a CO2 related disorder, it'll be respiratory. If it's not CO2 related, then we know hydrogens and bases are going to be somewhat affected. So if we just look at one of these, bicarbs, which is the major base of the human body, we can start to say, are bicarbs low? Are bicarbs high? Are CO2 levels high or CO2 levels low? And we can start to categorize them all based on this. It's pretty cool. I think it's real cool. For most AMP2 classes, that'll be enough work. Now, if you are in a medical program or a nursing program, you may be asked to go even further, and you're going to have to ask yourself whether the patient is already compensating or is it going through some sort of concomitant primary process, okay? And so that's going to be steps 4 and 5, where you're going to start to determine, based on whether it's metabolic acidosis, alkalosis, or respiratory acidosis, alkalosis, you're going to start asking whether it's an acute case or a chronic case. And I'll have to cover that in a different video because I want to make this a little bit shorter. But there are ways to go about that by doing things like, if it's metabolic acidosis, you take Winter's formula, right? If it is respiratory acidosis, you're actually going to look at some sort of the difference between the partial pressure and carbon dioxide levels and the bicarb levels. So there are ways about that. Okay, you're going to be looking at anion gaps and whatnot for the specific disorder if it's metabolic acidosis. Hopefully I didn't lose anybody there. That's for another video. That's a much more complex issue. But we can get a lot from these 3 steps. Take that patient's blood, look at their pH, look at their bicarb and partial pressure of CO2 levels. Let's do a practice on this, and that's kind of what it really comes down to, is that we can practice these studies. It's extremely helpful in our understanding of how to do these problems. So say for instance you get some blood work back, okay? In that blood work you're going to have the patient's pH value. So I'm going to start a table, and I think that's probably the easiest way to go about writing these things out for a student that is just learning how to do this. You're going to write a pH, and you're going to write, I actually always do the carbon dioxide levels next, so partial pressure of CO2, and the last thing I'm going to write in are bicarb levels. Awesome. So now I have a table here. On my table, I want to say what is normal. You always want to know what is normal. You never want to try to approach this by just saying, what's wrong with my patient? You need to say, what is normal, what is expected, therefore what is different about my patient, right? So if normal for pH, we know this one, 7.35 to 7.45. The partial pressure of carbon dioxide, normal is 35 to 45 millimeters of mercury. This is from respiratory system studies. Bicarb is not one that I've taught yet. This will be the first time that I teach that. It's 22 to 26 milliequivalents per liter. And don't overthink milliequivalents. It's just mass over volume is what's going on here. So what do we know about this? If it's greater than 7.45, it's alkalosis. If it's less than 7.35, it's acidosis. But let's think about CO2 real quick. Stop and think about CO2. CO2 is the #1 source of acid, right? It makes carbonic acid. So if it's greater than 45, if the patient's blood work comes back greater than 45, what do you think that that patient would have? Acidosis. If it's less than 35, we would say maybe they have alkalosis. We'll come back to that in just a second. Bicarb levels. Bicarb is the buffer, right? So bicarb, if it's greater than 26, we have too much buffer for hydrogens. So if we have a greater value than 26, that would indicate alkalosis. This is when base levels are high, versus when base levels are low, we would expect to have acidosis. So let's do a problem. Let's look at an actual patient. And we'll just kind of make up some values as we go. But let's say that the first patient, it doesn't really matter what the values are, but let's say patient 1 has a pH of 7.6. All right, cool. What do you already know about this patient? Immediately, we know this patient has alkalosis. There should be no doubt in your mind that this patient has alkalosis. Period. End of story. Don't let any other value down below trick you up. Okay, let's look at this patient's partial pressure of carbon dioxide, and let's say, for instance, this patient has 18. Doesn't really matter, it's arbitrary. I mean, it does matter, of course, for the patient, and it would matter for the ultimate diagnostic, but for the purpose of this problem, it doesn't really matter. So what do we know? If partial pressure carbon dioxide levels are too low, that means that H levels are low, right? Hydrogen concentrations are low. That tells us that tells us alkalosis. Not metabolic. Nix that. Not metabolic. It just tells us alkalosis. So we're going to write that down. So now we have alkalosis and we have alkalosis. This patient's blood work's going to come back, hopefully with bicarb levels, though. And let's say, for instance, this patient's bicarb level is, just to keep things even, let's go ahead and say this patient has bicarb levels of 18 milliequivalent per liter. Don't overthink this. Just write down what you would expect this patient to have based on this single value. Don't worry about the other two values. They don't matter yet. Just one value at a time. So 18. When bicarb levels are too low, we say, oh, this patient has acidosis. That's weird. The good news is we're not just looking at that variable, but it's going to be important in our final diagnostics of this patient. Because this patient has a blood pH of alkalosis. We know that they have alkalosis, period, end of story. The next step is to determine which of these values match with the known pH. There's only one that matches here, right? And that is carbon dioxide. That matches. And if it matches, that's their disorder. Period. End of story. If it's a CO2 related disorder, then the CO2 will match the disorder. Awesome. So, what do we know this patient has? Respiratory alkalosis. So, some of you should be asking the question, what the hell's going on with bicarb then? What's going on with bicarb? Why are bicarb levels so low? What do we know the human body is always trying to do? It's always trying to compensate. And if this patient has alkalosis, their body's trying to compensate for that alkalosis. And what is the level of compensatory mechanisms? Remember, the first compensatory mechanism, I don't want to use that color. The first compensatory mechanism, this was in my last video. The first compensatory mechanism was buffers. The second compensatory mechanism is respiratory. And the third compensatory mechanism was renal. So if we have a scenario now where bicarb levels are super low, well, that's because the body's trying to compensate. We are alkaline. We don't want more bicarb. We want to get rid of it. That's why this level is low, and that's why it indicates acidosis, but it's not, because this patient has alkalosis. It's trying to compensate. So why is this opposite? Compensation. We're peeing out bicarb. We're trying to reduce the number of those buffers in the system. Let's look at one more patient, just so you guys can get this hammered home. So patient 2. Again, it doesn't really matter what values we end up using here. But let's go ahead and do one where this patient has a low blood pH. Okay, the pH is 7.2. This pH value is low. Shh, shh. Young man, I'm trying to do a video. I know. Okay, now I have a 3.5-year-old standing on my desk. Well, it happens, right? So, what do we know about this here patient? We know this patient has acidosis. We don't care about anything else right now. The first thing we say is, what is this patient's pH? Awesome, it's 7.2, therefore they have acidosis. All right, so let's look at the next value. Let's say that, for instance, the partial pressure of carbon dioxide is... let's go ahead and say that the partial pressure of carbon dioxide is 31 millimeters of mercury. What do we know is going on there? All right. Don't worry about what we just did with pH now. This is a separate entity. Let's just look at this one by itself. 31 millimeters of mercury means that the partial pressure of carbon dioxide is too low. And if it's too low, what are we going to write over here? We're going to write alkalosis. This doesn't match. There's a reason for that. What do you guys think is going to go on with the third value? The third value is probably going to match, right? So let's go ahead and look in here on this patient. This patient's going to, let's make it pretty severe. Let's go ahead and say that we're at 11 milliequivalents per liter. Right? But hopefully you guys can see this is low bicarb. If it's low bicarb, then it matches acidosis. Shh. Hey, Beckett. Shh, please. Please. Okay, acidosis and acidosis now match here. 7.2 and 11. These match. So what do we know this patient has? We know this patient has metabolic acidosis. Why does the partial pressure of CO2 look like this patient has alkalosis? And the answer, yet again, has to do with, let's use the same color, has to do with compensation. How is this patient trying to compensate? CO2, respiratory system, is the respiratory system speeding up or slowing down? CO2 levels are too low. That means that the patient's breathing super fast. This patient is going to walk through the door with hyperventilation as a compensatory mechanism. You're going to be able to mark down on your sheets high respiratory rate, probably deep breathing at the same time, trying to compensate for this metabolic acidosis. Not too shabby, I don't think, right? Not too shabby at all. But I still want to walk you guys through a few more steps. Just so you guys can think, if a patient has respiratory alkalosis, let's tie it in over here. Okay, what sort of disorders might this patient have? Boom, we got it all written down over here. Maybe this patient's pregnant. Maybe this patient has hypoxia for whatever reason. Probably not going through an active panic attack, but you never know, right? But there's a lot of other things like acute pneumonia, acute pulmonary edema, so forth, so on. The second patient, what might they have? What possible cause for this acid-base imbalance might we have? Well, it's metabolic acidosis here, right? And so metabolic acidosis is going to be up here. So what possible causes? Maybe this patient just has severe diarrhea, or maybe they have unchecked diabetes, or maybe they have the worst disease of all, right? They're just exercising. You never know how that's going to work. Okay, the next thing I want you to continue to think about is how are we going to go through compensations? It's done. 1 second. I'm almost done. Yes, I know. 1 second. Pretty please. Okay, the last part of this compensation. Compensation, compensation. What I want you guys to think about is if a patient has respiratory alkalosis, what might their body be doing to try to compensate for this? What do we already know? The first compensatory mechanism is buffers. So are all of these chemical buffers that are in the system, whether or not they're bicarb reserve buffers or protein buffers or hemoglobin or phosphate buffers, it doesn't really matter. What are they going to be doing? Are they going to be releasing hydrogens or are they going to be binding hydrogens up? Well, if we have respiratory alkalosis, do we want to release hydrogens or do we want to bind hydrogens up? We want to release those hydrogens, right? If we bound up a hydrogens, we become even more alkaline. So in this particular case, respiratory alkalosis, we can imagine that this patient is going to be releasing hydrogens and trying to get rid of bicarbs. Awesome. What about the second one? In the second scenario, right, the second compensatory mechanism, what do we know is going on? This patient has alkalosis, and in alkalosis, the patient's going to try to hyperventilate to fix that problem. So this patient might come through the door and they have increased pulmonary ventilation. However, a patient with a respiratory disorder cannot use the respiratory system to fix that disorder because the respiratory system is broken. So they might be hyperventilating, but they are not going to be able to compensate for this issue no matter what. So that is going to be a severe disease no matter what. Last but not least, this renal system. What do we know about the renal system? The renal system is all whether or not it's a type A intercalated cell or if it's a type B. And what do we know about type A? Type A is always secreting hydrogens and reabsorbing bicarbs. What do we know about type B? It's always secreting bicarbs and reabsorbing hydrogens. These are those intercalated cells. So which of those is this patient going to have? If they have alkalosis, this patient is going to be trying to do what? I mentioned it earlier. This patient's going to be trying to pee out bicarbs and retain hydrogens. So which of these intercalated cells is going to be highly active in this patient? It's going to be type B, right? Any patient with alkalosis is going to have type B intercalated cells that are going to be working in overdrive. Why is that important? What do you know about this patient's urine? It's going to match their disorder. This patient has alkalosis, therefore their urine will be alkaline as they try to get rid of bicarbs and retain hydrogens. In our second patient over here, we have acidosis. It's metabolic acidosis. How are they going to be trying to compensate? Buffers. What buffer is going to be playing a lead role in this? Bicarb. Bicarb and other basic buffers are going to be trying to, are they going to try to bind up or release hydrogens? If we have acidosis, do we want to release more hydrogens? No, that would make it more acidic. So those buffers want to try to bind those hydrogens up. So that's going to be our base buffers, right? Respiratory system, we have acidosis. I just realized that I was talking so fast and my kid was distracting me that I said this one wrong back here, and I apologize about that. That's not like me. But respiratory alkalosis, of course, this patient's not going to be compensating with an increase in breathing. This patient's going to be compensating with a decrease in breathing. As they try to compensate with decreasing breathing, they're going to be retaining more CO2. And as they retain more CO2, their body converts it to more hydrogen. I'm so sorry about that. I was severely distracted. That is not like me. If you have me as a professor, you know that I try not to get that distracted. Okay, so back to acidosis. What do you know about a patient with acidosis? Are they going to be breathing super fast or are they going to be breathing super slow? Well, they have acidosis, so they're going to be trying to blow out CO2 because they're trying to get rid of those acids, right? And the more CO2 you can get rid of, the less acid your body will make. So as a compensatory mechanism, in this patient, the respiratory system is going to increase and pulmonary ventilation increases. Can a patient with metabolic acidosis, will the respiratory system potentially fix the problem or compensate properly for it? Absolutely, in the short term it will, because it's not a respiratory disorder. Finally, the renal compensation. What do we know is going to be active in a case of acidosis? Type A or type B intercalated cells? Type A secrete hydrogen. We have acidosis, we want to get rid of that hydrogen, therefore we are secreting those hydrogens. Type A intercalated cells is the answer. Therefore, what would you expect about the pH of that patient's urine? It's going to be pretty acidic because they're secreting out hydrogens. All right, that's the end of that story. I really hope that it was helpful. Please ask as many questions as you want down below.